racial and ethnic minorities disproportionately affected by COVID-19? Since early to mid-April, we've seen increasing news coverage on racial health disparities in COVID-19. Excess incidence, prevalence, or mortality relative to a group's proportion of the population generally constitutes a health disparity. A key distinction between health differences and health disparities is that there is some basis of social disadvantage, which results in differences that are unjust and avoidable. We've seen ample evidence that African Americans, Latinos, and Native Americans are disproportionately impacted by COVID-19. As shown here, of the 37 states with accessible race data, a disparity exists in Black mortality with the exception of 6 states. In New York City, there are stark disparities in cases, hospitalization, and mortality. Among all of these, African Americans and Latinos have higher rates per 100,000 in the population than whites. They make up larger proportions of the impacted population relative to their population size. Although data on Native Americans is limited, there is some evidence of disproportionate impact. In New Mexico, Native Americans make up about 11% of the state's population, but constitute over 36% of the cases. If the Navajo Nation were a U.S. state, it would rank third in case rates, only behind New York and New Jersey. It's evident that racial disparities exist in COVID-19, so it's important that we understand why this is the case. Policymakers have explained these disparities by stating that these populations have high rates of comorbidities associated with hospitalizations and death due to COVID-19. But why do these groups have a disproportionate rate of chronic illness? The answer is racial health disparities. Racial health disparities have persisted over time. They exist in most chronic illnesses, functional limitation and disability, and life expectancy and total mortality. Early research on health disparities focused on biological differences across races. Modern scientific research has revealed that human genetic variation does not naturally aggregate individuals into groups that match racial categories. Therefore, racial categories are social rather than biological. Most scientists have now rejected the notion that health disparities reflect biological differences. The sociological study of health disparities in the U.S. began with the work of W.E.B. Du Bois. In his book, The Philadelphia Negro, he suggested that poor health among Black Americans was an indicator of racial inequality, and that the health disparities were due to the vastly different living conditions between whites and Blacks. Since Du Bois' groundbreaking work, social scientists have continued to bring attention to the social determinants of health. So how does race operate to produce health disparities? The short answer is racism, in the form of institutional discrimination as well as interpersonal discrimination, and this includes access and bias in healthcare. The biggest example of institutional discrimination is residential segregation, the physical separation of two or more groups into different neighborhoods. The Civil Rights Act of 1968 contained the Fair Housing Act. However, segregation continues due to local and federal de facto policies, including racial steering and predatory mortgage lending. Living in segregated neighborhoods limits access to quality education and employment. It also concentrates poverty and social disadvantage. Black Americans are still the most segregated racial group. Even though our state is 80% non-Hispanic white, we can still observe a demarcation in minority neighborhoods in Salt Lake City. Segregated neighborhoods are characterized by food deserts where there's a lack of supermarkets to find nutritious and affordable food. There's high levels of advertising and sales of alcohol, tobacco, and fast food outlets. There's poor infrastructure and institutional neglect. There's poor quality housing, lack of sidewalks, parks, or other safe areas of recreation. There's an issue in environmental injustice as well. There's an increased exposure to toxins, poor quality air and water, among other environmental risks. So poverty and social disorder are happening at the community level, which yields high exposure to chronic stress and hardship. Overall, these neighborhoods have low property values, they're institutionally neglected, and they lack political representation. Similarly, Blacks and Latinos are more likely to live in segregated neighborhoods with concentrated poverty, which means that 40% or more of the households have an income at or below the federal poverty threshold. When we see the spatial distribution of COVID-19, a clear pattern emerges. Neighborhoods inhabited by people of color and the poor are predominantly affected. We see this in San Francisco, where the disadvantaged communities are the same ones that are harder hit by COVID-19 cases. In Milwaukee and Chicago, we observe that African American neighborhoods have higher rates of COVID-19 cases and deaths. Interpersonal discrimination is also a chronic stressor, and it is associated with both physical and mental illness. It also affects how much people use healthcare and how much they follow their doctor's orders. So how does racial inequality get under the skin? All of us experience stress. However, a persistent exposure to adverse circumstances can lead to a chronic activation of the stress response, which in turn triggers a physiological wear and tear effect, known as the allostatic load. A high allostatic load is associated with chronic disease, premature death, and worse overall health. Structural and individual experiences of racism increase the allostatic load, making minoritized communities more susceptible to chronic illness. Chronic high levels of stress, or a high allostatic load, then increases the risk of cardiovascular disease, diabetes, hypertension, obesity, and other comorbidities associated with COVID-19 hospitalization and death. Furthermore, Black Americans and Latinos have higher rates of uninsurance, which makes it harder to prevent, diagnose, and manage chronic illness. People of color are also more likely to receive subpar treatment in clinical settings. Racial disparities in medical treatment are consistently found and remain after adjusting for socioeconomic and healthcare-related access. Minorities are more likely to go through undesirable procedures, such as amputations or dialysis, or more likely to be ignored by their physician. In media outlets, Black Americans are raising awareness about the lack of testing and treatment in their own communities. Furthermore, people of color are being blamed for their high incidence, hospitalization, and mortality due to COVID-19. The Surgeon General has suggested to stop alcohol and drugs when asked about racial health disparities. Similarly, other public figures are asking Black communities to make big changes in their personal lives. This discourse erases the structural inequalities that hinder minority communities from having optimal health. Thank you.